Good morning, everyone. I'm Salina Nordstrom. I'm here to present to you. We're going to be talking about a few things. Mainly, we're going to be talking about when to decipher what is an emergency and what is an emergency from head to toe. Again, my name is Salina Nordstrom. I'm a nurse practitioner for the last 13 years. I'll give you a little history of where I started as a nurse to begin with. About over 20 years ago, I started the BOCES LPN program. While I was in the program, I became a certified nursing assistant, and I worked with subacute rehab patients back in New Jersey. And then once I became an LPN, I started working with the MRDD population, such as yourselves. I worked at Venture for about 2 years, and then I looked to forward my education again while I was with my LPN. And I worked with Jawonio. I worked at the Fisher Building for about 2.5 years, almost 2.5 years, right, Marissa? Yeah. Worked every weekend as a 20-year-old student, going for my BSN, but that's what I had to do, and graduate then with my BSN from Dominican, and worked, again, I wanted to further my education, so I left this population. I joined a city hospital, Montefiore. At that point, I worked as a float RN to get my feet wet, so to say. I worked everywhere and anywhere, and I pretty much started with med-surg and did all the basics, because before you go into an emergency medicine or critical care, you have to have some basic nursing skills. So then the next years, I then joined their float position as the critical care unit. Went from the ER and to the critical care to CCU, and that's where I found what I loved. I love working in the ER. While I was working obviously as an RN, I was also in school full-time as my nurse practitioner at PACE. Finished that in 2000. I stayed with Montefiore once I finished my NP program, and I worked in the cardiology unit. But then again, I still wanted the ER. Trying to work my way into the ER again. Started working there for about 6 months, and then I relocated to South Carolina. Me and my husband packed up and moved there. Went to join their ER team, and I did. But then I started having children, so I came back to New York. From there, then I basically stayed here. I worked at Westchester Medical in their emergency department. And then about 2 years ago, I left Westchester Medical and I joined St. John's. St. John's somewhere on my shirt. Going there next, that's why. Working their emergency room department, and I love it. But then I also love working with this population. So about 1.5 years ago, Dr. Shapiro interviewed me and asked me if I'd like to come on board again. And I actually do enjoy working with this population, mainly because this is a different type of responsibility. We have a responsibility to be compassionate. We have a responsibility to be more responsible. This is a clientele that cannot speak for themselves. They can't voice their opinions. They cannot say, I hurt, or this is wrong, or this is right. And to me, that's something I like. I like that little extra role. I like, the ER because it's instant gratification, but I like this role because, again, we are their voice. We are the ones that make their decision for them. So it's very important that we be compassionate. We don't know where they all came from. They could have came from a home that wasn't so caring and compassionate, and then you're seeing them coming to an area that's very frightful for them. And not having patience is the biggest thing. If you don't have patience with this population, then you're really not going to get anywhere with your patients. The biggest thing that you could take out of this, really, honestly, is when you go to the emergency room, understand that this population is not always fit for the emergency room. The emergency room is very loud, it's very chaotic, it's very disorganized. So if you really don't have to send a patient to the ER, that's a very smart thing not to send a patient such as these patients to the hospital, because they cannot understand the dynamics of a hospital like you and I can. We can understand the ER could be busy, and the next minute you don't see the doctor for 2 hours. They don't understand that noise behind them could be patient being brought back to life or being sutured or whatever it may be. So that's the biggest thing if you could take from this, knowing when to send a patient really to the ER. So being said that, I will begin. I'm a mother of 4 working 2 jobs, and I'm here to talk about everything with you guys. So let's do this. First time presenting in front of anybody, so I speak very quick, as you see already, and there's nothing I can do to slow that down, maybe a little bit. So if I start talking too fast, just do like this, and I won't mind. I'm very approachable. If you ever see me, I work at the health clinic now with Dr. Shapiro, Nancy, Alicia, and Barbara. So if any time you ever have a question about anything, if you're not sure to send a patient, and I'm working this, because I'm only here on Wednesday, if I'm here, come approach me. I'm very easy to talk to. You can pick up the phone, call me. But, however, just to make your life a little easier as a nurse. Okay? So let's begin. We're going to talk about the neuro. We'll start from the top. So we're talking about neuro. What we're going to talk about is TIA versus CVA. For those who don't know what TIA is, basically a trans-ischemic attack. And basically, it's the same thing as a CVA, but it's less severe. Symptoms come on pretty much the same way. They come on quickly. It's basically a stroke versus TIA. That's what we're going to talk about. TIA is something that, like again, happens quickly, but it resolves quickly. So someone might have a facial droop, someone might have a slurred speech, but by the time you get EMS there, they might have already been resolved. That doesn't mean you don't send them to the hospital. The reason why you don't send them to the hospital is because usually someone that's had a TIA, yes, they might be in their middle age or older group or younger group, but usually it shows half of the patients that had a TIA will, in some point in the next year, have a stroke. So if you don't act upon it, you might have a person that's TIA, call EMS, you don't send them to the emergency room for whatever reason, but then an hour later, their symptoms come back. That probably is not a TIA, that's probably now a stroke happening. So it can happen in the next 10 minutes and it can happen in the next 6 months. Being said that, what we do usually is we stabilize the patient. If we find it's just a TIA, we put them on some medication. We prevent the stroke part of it all. Usually do beta blockers, blood thinners, get them on a healthy management, diet, exercise, things like that. Look at their comorbidities such as diabetes, high cholesterol. The CVA, once someone's had a CVA, again, you're going to know it. They're going to have, usually it's more traumatic, and the reason why is because you're going to see it. It's prominent. They're going to have that continued facial droop. They're going to have weakness on one side. They're going to have something that's going to say, I need to send this patient. What you can do, basically, stabilize the patient, oxygenate the patient. Here, I'm saying if it's at the home or at the place, do not give them an aspirin. The biggest reason people say, oh, give them aspirin, give them aspirin. Truth, you don't give a person an aspirin until you know if it's ischemic versus hemorrhagic. If someone's having a hemorrhagic bleed, which means there's bleeding in the brain, you go give them aspirin. There you go, opening up for a can of worms. So aspirin's good in certain situations, not necessary unless we know it's a bleed versus not a bleed. So the best thing you could do is just stabilize them. If their blood pressure's high and you guys can give something, you can definitely give them a beta blocker. And the reason why is because anybody with a higher blood pressure is causing more stricture and more pressure and more trauma to that brain. You get that blood pressure down. Our goal is normally, if someone's 200 over 100, we normally like to drop them 20 points by every hour. But that's not for you guys to worry about. What you need to do is you can give them a beta blocker for 200 over 100. Pulse is in the 80s, that's fine. Even in the 70s. You know, we could deal with the lower blood pressure. Once the EMS comes out, give them some fluids. But to get that blood pressure down is so key. It's it's unbelievable. That's the first and foremost thing to do with a patient, besides seeing what's the cause of it with the CT. What else? Let me just see. Headaches. Headaches, people think, oh, send to the ER. Not unless it's the worst headache of their life. And the reason why is because normally that could be a hemorrhagic bleed. Or something more traumatic, maybe a tumor that's going. But a headache in general is not something you send to the ER. Try calling the doctor, try getting some analgesics, try getting them some oxygen. Oxygen a lot of times works for headaches, believe it or not. Just hydrating the patient, just giving them an extra liter of fluid if they can handle it. If they're not in CHF, meaning they're in heart failure, or someone has a kidney issue. Give them fluid, give them oxygen, give them rest, give them, cold, quiet environment that's dark, and just see if it goes away. I mean, I know I'm asking a lot from you guys, but sending a person to the ER to send them back, it's just so much more work for you guys in the long run, and for the patient, right? Obviously, weakness on one side, vomiting. Vomiting is something also that could be a tumor pressing or a bleed. So just because they have a headache, but if you see them vomiting, even if it's not the worst headache of their life, send them. Because again, that could be a bleed. This is something we'll decipher again with a CAT scan. Recent falls. I know you guys have a lot of falls here, which is a big thing. Usually, unless someone's fall involves a head, you don't send it to the ER unless I know you're worried about a break. Because if someone falls and goes down and comes right back up, I know you want to cover yourselves with ER, but try to have a doctor eyeball them before using the ER as like a diagnostic tool. Because that's just a lot of work for nothing. If I'm here, you can send them over to me. I'll eyeball someone. I have no problem looking at someone and say, we'll keep an eye on this person. There's no head involvement, no speech injuries, dentation's the same, baseline. You don't send the patient. I know you have to do it as far as covering yourselves, which I understand, because again, they can't voice when they have pain, but if we can stop that from happening, that would be great. But if they do have a head injury, they've fallen in last week, because they can have a slow bleed. Someone that falls today might not present with the problems, but 24 hours later, they might have some changes. They might have a visual difference. They might have a speech, impediment. Something might be going on. So then you might want to send, not necessarily to the ED, but call maybe the doctor, and they can order a head CT. You could send them right to, MRI. I think there's a place in New City, right? Do something like that again, because that will be a quick read. And if the person does need the ER, then at least they can go from there. But to send them again to the ER if you can, unless it's after hours, again, just try to decipher what you want to send the patient for. Your job, basically, again, include meds. Meds are very important when you come to the ER. A lot of times, I hate to say it, but my nurses are calling the nursing homes or wherever they're from usually, what's the correct med list? Because the symptoms are not presenting as someone, if we're not finding a reason why they aren't doing this. Sometimes they have digitoxin levels that are off the roof. They're toxic. But there's no list that they're on digoxin. So just make sure these lists are on point, because we see a lot of EKG changes. Again, a lot of them have to do with cardiac meds, blood pressure meds, and we're not seeing it on the med list, and then to find out they're on these medications. Time of onset, very, very important. If you have someone, again, neuro-wise, when did you first see the symptoms start? We have something we call TPA, which is a thrombolytic medication that can break up the clot if it's a clot that's making this person have symptoms. And if that's the case, know that this patient, all right, the eye started twitching, the face started drooping at 9:05 or 10:02, whatever the time is, because we have certain hours of window. We have to meet the criteria to give someone TPA. But once they're out of the window, they cannot get TPA, meaning we cannot break the clot up. They might have to go for stat surgery if, in fact, this person's even a candidate for surgery. Questions on that? Did I talk?
How long do you have?
Usually it's 3 hours. I mean, NIH, the criteria, the stroke scale we're a stroke center. So the criteria did change at one time, but it's back now pretty much at 3 hours. So if you see someone at 9, obviously it's now 1 o'clock, you're sending them, they're out of the window, but that doesn't mean we can't stabilize them. They just might have more residual, meaning more symptoms after all of this has resolved. So knowing that is key point, because again, we can't do much if someone's out of the window. I mean, there's other criteria. It's not so much the window. It also is age. It's also certain things we see on the patient. There's other things that they can fall out of the criteria to get TPA, but that's one of the main points with TPA. Again, I told you about do not give aspirin. All right, moving down from head to eyes. We're going to talk about eye emergencies. Biggest things with eye emergencies: visual changes, foreign bodies, trauma. Periorbital edema. Periorbital edema, we'll talk about that first. That could be a lot of times for medication. ACE inhibitors cause a lot of these issues, such as like your lisinoprils, anything with the prils at the end. That is a medical emergency. It's happening here. You don't know what's going to happen here next. So it could move down here very, very quickly. Periorbital edema also could be a cellulitis of the face moving on into this area, and that requires the patient to be admitted. Someone that has a cellulitis of the face, but it involves now the eyes, is pretty much an admission. So that's a good time to send the patient to the ER. Foreign bodies. Biggest point not to do with foreign bodies is do not apply a pressure to the eye. People think all the time, oh, it's bleeding, it's bleeding, it's bleeding, put pressure. What do we always think? Cover and pressure. Something like this you don't, because you actually can push it further and also cause more problems. A lot of times that foreign body might not penetrate all the way through the eyeball, and we can flick it out, usually a needle gauge. We use an 18 needle end of the gauge and just flick it right out a lot of times if it's something we can see that's not deep enough. But again, if you put pressure, it could be deep enough, then now this person has to go for surgery, or even lose the eye, or loses vision. Visual changes, all right, visual changes. This is the biggest thing. When you're sending a patient to the ER, if the patient wears glasses, please note on the paperwork, if the patient wears glasses, if you know the Snellen, which is the eye chart, if you know their Snellen baseline, if they're 20/40, 20/50, mention that if it's with glasses, without, so when we come in and we do our visual acuity, we'll know if this is baseline for the patient or is this something we have to work upon quickly. Someone has obviously you have trauma here. I mean, things can happen anytime. If you see someone's eye obviously hanging halfway out, you can stabilize it with a normal saline gauze. Saline is the best thing to pretty much wrap anything in with. If it's a prolapsed uterus, if it's a body part, if it's whatever, but it's sterile, normal saline, all right? That's the first and foremost to remember with that. Irrigate with normal saline for burns. Someone can come in antifreeze. I don't know what you have so much here, but like you have things in shop. Maybe they get something in their eye. They get a splash on. You irrigate with saline. Saline's pretty much safe for anything across the board as far as chemical burns or anything to the eyes. What else? And that you would cover the area because, again, sometimes the eye can actually irritate the eye more. Corneal abrasions, you cover the eye also until EMS comes or however they're going to the hospital. But cover the eye saline. If you can remember that, and do not apply pressure if it's a foreign body. That's it. Again, send medication list. That's a big and foremost. If someone's on, one of the eye drops for glaucoma or cataracts, that's important to know. Nosebleeds. We're moving down from the eyes to the nose. Biggest thing with nosebleeds, you don't send a patient to the hospital just because they have a nosebleed. You send them to the hospital if the nosebleed is not stopping. If they're on blood thinners such as Coumadin, not even if they're on aspirin. Aspirin in general, unless they're getting like whopping dosages, which no one really normally is on a basis, because our patients don't have those type of issues here. But anybody with Coumadin, even Zocor, that's not a big reason to send someone to the ER because the bleeding is now 10 minutes. Biggest thing you could try to do here is, a lot of people say, oh, do the lip, this. The best thing you take is 2 tongue blades, some tape. You take the 2 tongue blades like this, you tape the end on the bottom, and you pinch their nose. That's it. Try doing that and see if it resolves on its own. If it doesn't resolve on its own, the patient starts to choke, something like that, that means you need to send them, because that anterior bleed that you think's in the front could be a posterior and going down to the back. But try that. 2 tongue blades with tape. That would be the quickest, easiest trick I could tell you guys with nosebleeds until someone could come to get the patient over to the hospital. Because once they get to the hospital, we put these things called rhino rockets, which basically these things we blow up, put pressure, and we come back, have them come back in 2 days. We take them out and just clots off the bleeding, basically. Or we pack it, one or the other. But nosebleeds, that's really the only thing you need to worry about with nosebleeds. If they're on like Coumadin, because unless you know their INR level. If you know their INR level was, which everyone knows what INR level is here, all right. If the INR level is between therapeutic range. If they're sub-therapeutic, say yesterday, and dose was never changed, they're going to still be sub-therapeutic, meaning they're not going to be over-bleeding. That means if anything, their blood is too thick. So just try the 2 tongue blades. Moving. Ears. Bleeding from ears. Sudden rush of blood or serosinuous fluid could be a ruptured TM, tympanic membrane, so the eardrum could have ruptured. That you send to the ER because they need to just stabilize the patient, make sure they get on some antibiotics. Not so much for saving that ear, because for a ruptured TM you do nothing but protect it. But the main thing is covering them with an antibiotic, because now they're exposed to many germs, having that area opened up. So that's an emergency you can send over. Earaches obviously are not, I'm sure you guys don't send for earaches, so I'm not even going to approach that issue. But that's something just to cover. Your best thing, cover the ears again. Cover is the best thing to do, just don't apply pressure on certain areas, that's it. Mouth, dental emergencies. Cellulitis that involves not just of the mouth, but again up the face, into the eyes, because at that point they need an IV antibiotic. Pills will not work at this point. Sometimes thinking, to drain it, we can drain it, yes, but they still then again need IV antibiotics, which I know is very hard for you guys to do in the homes, right? Do you do antibiotics? No. So that would be an admission to the hospital. Not an emergency, dental pain, abscesses that are localized, meaning they're just in the mouth and swollen. It does not mean someone needs to go to the emergency room. You can call your physician, doctor can write over the phone, start the person on pen VK or amoxicillin, whatever his choice is, and get the patient started on the right medication. Broken teeth, not an emergency. There's nothing about a broken tooth that's an emergency. Even if it's bleeding and it's pain, you give some extra medication and put some ice and pressure. There's nothing to do. You do not send out to the ER. You can call a dental clinic and call and see if they can send over either to you. Do you take dental emergencies?
Absolutely.
Right. There we go. Dental emergency. That would work, because that would save, again, the patient from coming over. Moving down. Neck. Fever. Fever is a big thing. They have a lot of posterior neck pain, because that could be meningitis. Someone that has a fever and they're complaining of neck pain is something that you should take seriously until proven otherwise, because then at that point we'll do some blood work and see if they have, just because they don't have a count and they don't have a shift in their CBC doesn't mean they don't have a viral meningitis, but we'll decipher that once they come over. But that's important to know for neck. Obviously severe swollen nose is something you'd want to send over for too, because that might be something inside that you don't even know what's going on. Then we'll do a CAT scan of the soft tissue of the neck, and we'll see if we can see what's going on in the ER. But you could send someone over for severe swollen nose, not just little balls here and there. I'm talking about, you'll see it. You can see the difference. Neck also, thyroid. If someone has a thyroid issue, and you see their pulse is going through the roof, their heart rate, you see they're very anxious, they've been really jittery. Their sleep pattern has been different, send them over. They might be in thyroid storm. And that's a real big emergency. That requires pretty much all IV IV medication and severe monitoring. They need to go on a telemetry floor at that point. So that's someone to send in. If someone has a thyroid issue, you see that. Enlarged thyroid doesn't mean they're in storm. You need to have some symptoms, some clinical presentation, such as, like I said, the heart rate, the symptoms, is how their baseline is, they're just different. Cardio, chest pain. Chest pain's a big thing, because you don't know when it's serious and versus not serious. But the biggest thing you could take from a chest pain, if someone's complaining of chest pain, regardless if it's right-sided, left-sided, mid-sternal, on the arm, you send them to the ER, because they come in many different ways. I had a patient the other day that had epigastric pain. She was 37, and you know, she had an inferior wall MI. Very uncommon, but it happens. We see them pretty often. People coming in. I had a guy that runs normally 8 miles a day. This was about 3 weeks ago. Runs about 8 miles a day. Today he decided to go 10, so he thought the burning in his chest was the extra 2 miles he ran. 52 looked great. Coming in, he wasn't even in pain. He wasn't bent over. He wasn't grabbing his chest. He just said, I just have this really dull feeling sitting right here. I don't know if it's that my lungs are on fire from breathing. I just don't feel right. Put him on the monitor. He had an MI. We sent him over quick, capped him. Literally in a half hour, he was already under the table in the procedure room. And he had no residual. All the arteries are open back up. He had now 1 stent put in. So time is of the essence with chest pain, because it can happen to the oldest, the youngest, the healthiest, the fattest, whatever, skinniest. I'm just saying, it can happen to anyone. So it's very deceiving. That's one thing if you could take from that. Just knowing where your job is, though, here to what to do is to oxygenate the patient. Give them 2 baby aspirin. That's not going to hurt anyone. Everyone needs 2 baby aspirin. All right, that's the first and foremost thing you need to do. The main thing, though, you do not give nitro. Do you know why? Does anybody know why we don't use nitro? A what?
You can blow an MI with nitro.
You can. The problem is until you know nitro, you always say, oh, give oxygen, aspirin, nitro. That's the biggest thing. Unless you know that right ventricle is not involved, you do not give nitro. Because what happens is when you have that right ventricle, remember, it's filled from the left atrium. So that passively fills. If you give nitro, it drops the blood pressure. That means this blood pressure needs to come all the way back up, fill that left atria passively, and it's going to cause more problems with the right ventricle. Thus, for making the patient have more hypotension, you could kill the patient. So until EMS is there and they've stuck an EKG and know that that right ventricle is not involved, because there's a way we look at it on the EKG, you do not give nitro. Let them deal with the nitro bit. That's not your issue. Do not give. That's the one thing I can tell, because you can kill the patient just from waiting for EMS. They'll be literally bolusing the patient up the wazoo just to keep them up until we get them to the hospital. So just aspirin, oxygen, rest, quiet environment. That's the biggest thing, is quiet environment. These patients get very worked up very easily from the littlest things. And you know, what's normal to us is completely tenfold to them. So if you can just give them a quiet environment, they deserve that, at least. If you can get them comfortable, that's the main thing that you can do for them. Low pressure, I don't know if you guys can give low pressure here, but if the blood pressure, no.
We can't even do the baby aspirin.
No.
We can't do any of that.
Oh, no?
We're gonna have standing order.
You don't have a PRN order? No. So there's no one like to give that to you over the phone?
No.
So then drop it.
Well,
Well, in the
actually,
real world.
if we had standing orders, which we have just started.
Because that's something, that's a standard of practice, so I'm
Right.
surprised, at least the baby aspirin. I won't even talk about the low pressure, but that's fine either.
Will be 2 aspirin that you give?
2 baby, 162. If someone took, and that's another thing, some patients are already on aspirin, right? So they're on the baby aspirin. You give them another 162 is not a big deal. Because truthfully, the minimum stair cap practice is 162. The max is 325. So, and even if you give an extra, aspirin is not going to do anything but keep that blood going. And that's what these patients need at this point, is the blood going. Don't worry about it. We can fix all those other issues. Another aspirin or 2 is not going to be a big deal as long as it's 162. Questions? Oh, that's what you're saying.
Except for the fear of hemorrhage and a stroke. That's what you're
Yes,
saying.
yes, because you don't know if it's hemorrhagic. Correct. Good.
Sorry, if somebody's on anticoagulants, you can still give the
Yes,
aspirin too?
yes,
Oh.
yes, because it works in a completely different way. One is a different half-life. Yeah, it's just different. So, all right, so that's that with cardio. Moving on. See my little cheat sheets here. I'm not into PowerPoint, so I don't even know how to use that. So we're going to do it like that. Pulmonary. Moving down, let's see, I did the neck, heart. We did the heart, let's move on to the lungs. The biggest thing with the lungs is people not, this is the influenza season. Yeah, we're kind of out of the big stint about 3 weeks ago, even 4 weeks ago. We were really in it deep. Now we're coming out of it, but we might get another strain in about the next month. So being said that, be prepared if we have a next round of this influenza that you know the difference between a common cold and the influenza. Either way, you don't normally send either one to the ER because there's nothing to do with the influenza, but really just rest and nursing management, fluids, keeping an eye, fever management. Cold, pretty much the same thing. The only difference is that if you want to quarantine a patient versus, someone that maybe is just a common cold, these are points that you should know. Some of the points that you should know, usually a cold starts with sore throat, then kind of runs to the nose and then hits the chest. And the symptoms they can pretty much present the same way, but know that their virus for the cold is only contagious for about 3 days. The first 3 days, usually when they're having the rhinorrhea and this upper and sore throat. versus the influenza is contagious for 7 days. So even though you might have been a little sick, you probably have the flu, you're still contagious in that 7 window period. And that's what's scary because, you know, with the H1N1, you know, you have a window of opportunity to give that Tamiflu too, right? So if you don't even know if the person's in that window or not, we normally give Tamiflu just to cover. And even if they're out, they probably are out of the window, but at least we know if they're still in that window, their chance of passing that around is less. What else did I want to tell you? All right. Basically, influenza symptoms are stronger. You're going to have generalized body aches. Usually you're going to have a fever with an influenza. Normally a cold doesn't have a fever. I mean, sometimes, but it's not usual. Usually they're exhausted. They're just really run down, your clients. They don't look the same. A cold, I mean, they don't look as bad. You'll know when someone has influenza. So at that point, then you want to quarantine someone, keep them away from population for about 7 days. I mean, to the time of onset that you notice the symptoms. Because, they're contagious for 7 days. What else? Asthma exacerbations. I'm sure you get a lot of asthma attacks here. Biggest thing with that, again, get them oxygen. Try to give them a breathing treatment. Give them some good chest PT. You can do back-to-back nebulizer treatments. I mean, I know you probably orders a Q4 or whatever it is here, but if you have to get someone, call them. Say, listen, I got to give another one. Half hour later, he's still sounding like crap. Give another treatment. We do continuous nebulizers to infants, so what do you think it's going to do to these big people? Nothing. And that's the biggest thing because they need a lot of bronchodilation. And I know it's hard to get steroids on these people because a lot of them, you don't have the orders to give it. But the main thing you can do is oxygenate and give nebulizers. That you can do. I think that's in your scope of practice, right? You guys can do that? And chest PT. Chest PT is very important because your negative pressure, what you could do is take the bottom of an ambu bag, you know the mask from the ambu bags? Because the hand sometimes, you don't have a good seal, you're not really getting that pressure you need to get. You take an ambu bag, the mask, tape on the other side, you know, the part that connects to the actual pumper, use that. That's a perfect seal. And you can use that all throughout. And then what that does, it breaks up the secretions to thin them out so the patient probably can move them around. Because the best thing is getting them, those little balloons down here, opened up. If you don't open those little balloons, you know what's going to happen. The dilation of the medication is not going to do anything with the alveolar if you're not helping it move it along. So good chest PT is very, very important. People don't realize that. And you should do chest PT while either whoever, I don't know who does the treatments here. Do you do the treatments? You do the treatments? Or your aides?
No, we directors.
All right. Well, what you could do, whoever does the treatments, what they should do is while the person's getting the treatments is do the chest P at the same time because what it is, while they're, it's like a dual action, the patient will have a better outcome with each treatment when you're doing it. But again, that doesn't require an emergency unless the patient's really hypoxic, patient's really tachypnic, and I'm talking about in the 40s. I'm not talking about 28. 28 is not a number to send the patient to the ER. You know, and I'm talking about like it needs to be happening for a little bit, not just 5 minutes of 42 and then drop back down to 22. He needs to hold on, and you're going to see a lot of flaring. You're not going to see so much flaring with this population because they're older, but what you'll see is a lot of pulling in here and in here. You shouldn't see someone pulling here, meaning the air is getting pulled here, because these lungs, that means they're looking for areas and muscles to help them elsewhere. So if this area is compromised, they're going to start using accessory muscles, that's what we call it, which would be here and here for this type of population. For the children, you'll see the nasal flaring. What else to tell you about that? Let me just stay on track. Can you guys get Benadryl here for like someone that's having anaphylactic shock or anything? I mean, anaphylactic reaction? That's also important. You can give a little bit Benadryl too if you see someone having a little respiratory distress. Benadryl is not going to do anything if you're concerned that it could be, you know, maybe an allergen exposure versus just asthma. That will help open them up and kind of get those allergens out.
Just
so
get
you can
50.
focus. 50 IM. You give it IM? No? PO? PO, all right. That's if someone could swallow. But if someone's really in distress, you're obviously already on the phone with EMS, but you can at least give the Benadryl. IM? No.
We don't have that.
Or if you could slip it in the mouth, then fine. Truthfully, I mean, it's a small pill. Give them a little bit of water because you're working them hard. You don't want them to aspirate in the meanwhile while you're trying to work on their lungs, out in their lungs. I mean, in their lungs. So, all right. Being said that, questions about anything so far? Because I talked very quickly. Anyone, any questions? No? Everyone's okay? No, everyone understood what I'm saying? All right. Just raise your hand if you don't understand what I'm saying. Abdomen, fever and abdominal pain is a big deal.
Wait, Salina, with the neb, right? A common neb solution that you would use for anything if you have something available would be the albuterol.
Albuterol. You can give Atropine and albuterol together. One works versus the other, but you know you can give a dual neb. Is what we call it. You can give the albuterol Atropine. Atropine's not going to do anything right that moment. The albuterol is going to be the thing that's going to fix them. such as chest PT and giving them treatments. Give them back to back. So what, you slip another, I mean, I hate to say, I'm not on camera, right? Give an extra one. Give an extra, if that, you're not gonna do anything. I mean, you're not gonna do anything to this patient, you really are. Maybe the heart rate's gonna go up to 112, but so what? So
But
what?
they can breathe.
Heart rate will return to normal. All right, really. I mean, honestly, that's the best thing you could do for a patient. Abdomen. Let's talk about stomach now, right? Fever, abdominal pain is something we should send to the ER, and the reason why is because it could be diverticulitis, it could be colitis, and all these things. All these things require admissions. Not so much diverticulitis all the time, but a lot of these things require additional care because now they're nauseous, now they're vomiting, now they have diarrhea. So now a lot of times they're going to need electrolyte replacements. They're going to need fluid management. They're going to need IV antibiotics. They're going to need breast. They're going to need a GI consult. There's things involved. So send the person over because at that point, we need to stabilize them, especially with these clients. Some of them don't eat that well to begin with, so they lose a pound or two. It's a big deal for them. What else? Right lower quadrant pain. You know what I'm going at with that, right? Appendicitis. So if someone's grabbing here, even if they're pointing to their belly button, because that pain can radiate. Not normally all the way to the left side, unless it's severely that inflamed or even ruptured. They're already going to have a fever, and they're going to already look like crap if it's over on this side. But if they're complaining of right-sided pain, you need to send them over to the ER. And the reason why is because we need to make sure it's not appendicitis and God forbid let it rupture, because then it's an all other ballgame if it ruptures. What else? Constipation, big problem I know with your population. Obviously, you're not going to send them over to the ER if you tried nothing, like Miralax and this Fleets. But if they're still constipated 5 days later and they're just not doing well and they're vomiting, you send them over. They might have now an obstruction. That's the biggest thing you worry about this population because their stool's already hard. They're not moving and running around like we are. They're more, sedentary. They sit in a wheelchair all day. So, send them over after I would say even 5 days. I mean, I wouldn't say send them over in 3 days. 3 days, I mean, when was their last bowel movement? If it's 5 days or more, you send them. And that's pretty much a general rule. Even if someone's having 4 bowel movements a day and they're now only having 1 in 4 days, as far as sending to the ER, that doesn't mean their stomach's any smaller or any different than me and you. They can hold the stool. That just means their GI system runs a little bit quicker. But just keep an eye on the 5 is kind of like a golden rule. I mean, some are even 7, but with this population, I'd be safer than sorry. I do this 5 days. What's the earliest population you guys work with? What's the youngest? Everyone's pretty much an adult. Any pediatric nurses here? No? Okay. We'll talk about that piece. All right, let's see.
What is the youngest one now? 8, 12? They're all over to
Okay. So, uncontrolled nausea, vomiting, diarrhea. I just discussed it with you. Obviously, you need to send them over for that. Dysuria, which is meaning painful urination, hematuria, blood in the urine. Send them over. Flank pain, send them over. The reason why it could be not just a kidney stone, it could be something more severe. They could be an acute renal failure. There could be a few things going on. It might not just be a UTI. You know what, I mean, if you could if you can have someone eyeball them, that would be the ideal thing, especially for this year in hematuria, because it could be a UTI, yes. But it also could be a stone. I mean, if it's gross hematuria, you send them over regardless. If you think it's a UTI or not, you send them over. There's something going on, especially with the male population. They can have something wrong with their prostate at this point. Tenderness to that area with the guys. If your male clients have tenderness down there, especially on one side greater than the other, swelling on one testicle, they can have something called epididymis. They can have torsion. There could be a few things going on. This all involves, that area for the men. Women, obviously, if you have vaginal bleeding on a woman that's already menopausal, you send them over. If they're uncontrolled bleeding, not so much that their bleeding just started, because it could be fibroids. It could be something else that's kicking in their bleeding. But at the point that they're causing abdominal pain and fever and bleeding, you send them over. Because at that point there might be some infectious process, might be a tumor growing, something that, needs to look like immediately versus later. Let's see. Extremities. Did I hit everything already? That piece? Yeah. Extremities. Fractures. You have a lot of people that fall here again. Fractures. What do you guys normally do for fractures here? Stabilize. Do you know how to stabilize a fracture here? So do you normally know it's before the so if the fracture's here, you always stabilize the joint before and after. You guys know that? All right. If you don't have this stuff, what do you guys do normally? Do you always have something around to splint it?
Still.
All right. If the person can't keep still, say if they're thrashing around, some of these patients, they get agitated very easy. You take 2 workbooks, wherever you're at, 2 workbooks, because they have a strong. you take one on this side, one on this side, and you take an ACE wrap. Just close it up because they cannot injure it more than it is. But if you just keep them quiet and they start to get agitated, you can displace that fracture, meaning the fracture that was like this can become like this, and then it can become open, meaning goes through the skin. Then it's another ball game too. They have to get IV antibiotics because now they're exposed to, their nervous system is exposed to some big germs. So that you could do 2 workbooks and just an ACE wrap, or I'm trying to think what you have around here.
Would it be worth getting splints and having splints?
How often does it happen? You can always get your hand stuff a workbook, can't you? Pretty much. Yes.
Yeah.
And the workbook has the back side of it is pretty strong. What I'm saying is because that piece will act as your splint, and just ACE wrap it or Curl-X, whatever you have, just to keep it from falling off. So that if the patient moves around, that fracture is as stable as you're going to possibly get until EMS gets here, or however you're sending the patient to the ER. A lot of people don't realize that, but little things over the counter work a long way. Let's see, bites. Bites can happen, human bites, right? So the biggest thing when you send to the patient to the ER is know who bit the patient. If anyone knows if they're HIV positive or Hep B positive, send that over. That's very important to know because we can start the right treatment for this patient that's coming into the ER to get the right medication. That's the biggest thing. People don't realize, what about the patient that bit the person? We need to know about that person too. So send that with them.
Would all HB bites be treated?
Age what?
Hep B.
Yeah, we treat them. You know why we treat them? Because unless you could get, the person to consent, the one that bit them, consent to give blood work again, you better to treat than not treat. Now you guys are all seeing the HIV consent packets going out from anyone from 13 to 64. That was started because people think, I'm having sexual intercourse and, I'm not having sexual intercourse, I'm not going to have HIV. But, it's anyone from soup to nuts. Any population can get it, from dental cleanings, not trying to say you. Anything, could be anything. Transfusions, it could be, the smallest little contact with someone that was direct contact. They don't know. These clients can't tell us everything they've done from the day they were born. So, being said that, you treat everyone.
But if you have someone who is Hep
B positive, you treat them.
How would they be treated?
They usually treat them with it's a 3-packet medication. We give them through the ER. We give them the 3 pills there, and then what happens? We send them home with a script. It's usually about a month, and we refer them to follow up with their doctor. Can they decline the medications? Yes. That's if they have the capacity.
What medication is it?
It's you know what? It's don't quote me on this. It's Combivir, the AZT, and there's another one, Norvir. There's 3 of them. There's a combination of them, and I don't know because the nurses give it. I don't have. We
That's
basically.
for HIV exposure.
Yeah.
I'm talking Hep B.
Hep B, what we do, right, well, we treat them for both, is what I'm saying. For Hep B, what we normally do is do titers on the patient. We do the antigens, we do the immunoglobulins, but we basically treat the HIV. We don't always treat the Hep B, unless they're Hep B. It really depends on where they're at. We do everything from soup to nuts. We do all the blood work there. Once we get back our panels, we discuss it with them. Some of them don't come back right away, so if they do come back and the patient's home, we call them up, we follow up, and then we say, this is the course of treatment we need to put you on. But everyone gets treated like HIV regardless. That's our biggest thing in the ER, unless they decline it, and they have the capacity to decline it. But we treat them because, you don't know. Hep B status, but, not everyone gets tested for HIV. Now we're doing it with these packets, but not everyone's saying yes. Not everybody's there.
We have a problem with our population about consenting. We can't just do it if we don't.
Yeah, you gotta get a legal guardian, right? Yeah,
So
that's
it's not
what,
so easy with us.
stepping away from here, I have to sip, sorry. Sorry, I have 4 kids. I'm bent over right now. So what are you doing?
We're not.
You're not testing?
Well, you're saying the age group on this consent business,
Thir-
13 to 64, so
64.
my older ladies don't
Yeah,
even. I
technically,
just send back no.
yeah, technically it's New York State is doing it as a screening tool from that age population. It started really before it even hit here, about, I guess, early 2011. We were getting it in the ER and everyone had to get, give us the consent, yes or no, and then it came here, I guess, last year, Barbara?
Yeah.
Right? So, if you could do it, that would be the best way to do it. What?
I'm saying, my organization, this is the first I'm hearing. We somehow fall off these lists. I don't know.
Where are you, in a house or?
Agency, yeah.
No, because some of these, I know clients are in ICF versus,
Yeah.
no, okay.
Yeah.
All right.
I just wanted to ask you a question about the bite. They do bite each other in this population.
Yeah.
I don't usually get excited if the skin's not broken. Is that
Don't
inappropriate?
get excited.
Okay.
don't get excited, but the main thing is, you should have the person have some levels done, regardless, just to know like what their baseline, maybe you don't know, they're, for next time, it's not so much for this time, but like, say if this is a recurrent thing, you should be worried about, are their antibodies strong enough to handle the next bite, things like that, just so we can bump up their system with vaccinations. Okay. Any questions? Moving on? Okay. Allergic reactions, again, Benadryl. Give Benadryl again, that's the biggest thing. If someone's having an airway issue, it's only gonna get worse. You're only seeing them in the first few minutes, you don't know what's gonna happen. Some of these medications that they take that have a reaction, their half-life and they don't peak until an hour or two later after they take it. So what you're seeing now could completely be so worse in the next hour. Just call EMS. It's better to do it that way if they're having a reaction, especially if it's, and I'm not talking about just hives, I'm talking about something up in this area, and especially patients that are asthmatic, because they're going to be higher chances of having respiratory issues too, because again, they're probably going to go into, bronchospasms just by the reaction itself. Their histamines will be thrown out.
What about EpiPens? Are they doing
EpiPen.
repeat?
What do you mean?
I know some private doctors are ordering the EpiPen, they're ordering them in two. And if it doesn't work with the first one, wait 5 minutes.
5
repeat.
minutes, same thing,
Okay.
it's 5 minutes,
Is
yes.
that the standard now? Because not all doctors are ordering
Not
it.
necessarily, I don't know if there's really a standard per se, it's just really what's your choice of preference of care. You have to be careful with epinephrine, it's expensive on tachycardia, so, that's the biggest thing. If someone's already got a heart issue and they're in AFib, and you go throwing an EpiPen on them, who knows what's gonna happen, so be very careful of and selective who use that EpiPen before giving Benadryl. Unless obviously someone's having reactions, like you save them, you deal with the heart. I mean, yes,
Yeah.
that's a different situation, but don't just be quick to take that EpiPen versus trying just basic Benadryl.
But a lot of times the doctors aren't even ordering Benadryl, they're just saying, for someone with like a known peanut allergy.
Right.
EpiPen, they're not ordering Benadryl first.
Okay, but are they having issues like as far as, cardiac issues? You're seeing
No, most of them are young people
That's
with
fine,
peanut allergies.
that's fine, because their body's gonna be able to react to that epinephrine just fine. I'm talking about someone that, in general, epinephrine works in many ways, but the biggest thing with a normal person, they'll rebound back perfectly fine. Maybe they'll be a little tachycardic, we'll watch them for a little bit and send them home. But an older person that, obviously has already some cardiac issues, I would be not quick to give that, I'd give some Benadryl.
Yeah.
And I'd actually have you guys call the doctor and say, listen, this person, by the way, do you know he has AFib? Do you know, by the way, he has CHF? Do you know this person normally carries a heart rate of 102? Can we try Benadryl also standing order just in case? Because you don't want to wait until the emergency happens and then you're stuck like, oh my God, what do I do? What do I do?
Good
Have
idea.
the order cover yourselves. What else? That's that. All right. Other types. Dehydration. Someone's dehydrated. That's very common here. Check the vital signs. If they're, able to take some things by mouth, just pumping up with a lot of fluids before saying, oh, I'm just going to send them to the ER. This might just be a running about, little bit of a cold. Maybe they're just having a bad day. Don't think, oh my gosh, they're not drinking, they're not eating. But if they're still peeing and their urine is not so concentrated like dark orange, give it a chance. Let their body try to kick it on themselves. Try to let them deal with some of these things on their own. Unless someone's really hypotensive, meaning their blood pressure is really, really low, pulse is really, really high, and this has been a few days, then you're obviously going to send them, because no matter what you do here, they're going to need some of this, right? All right. When to go to the ER. I'm just going to run some main points to you, and I think we're almost done.
Yeah, we're almost done,
'Cause
I
I
know
was
there's
like,
another
so-
meeting coming
I
in.
was like kind of late.
So,
too.
yeah.
I'm gonna read this because I wrote a lot of things, so don't mind me. When to go to the ER. Loss of consciousness, obviously. Signs and symptoms of an MI, which is a heart attack. CVA, signs and symptoms of a CVA, which I kind of gently touched, but I'm sure you guys know a little bit about that. Unrelieved severe shortness of breath, that's the biggest thing. I mean, you can't fix it, you send them, because it's only going to get worse. They might need intubation. Bleeding greater than 10 minutes. Remember I was saying about the epitaxis, try doing the nosebleed with the tongue blades. If that doesn't get better, send them over. Poisoning, obviously, but you're always going to call Poison Control Center first. Why? Because there's a lot of things you could do before EMS even gets there, such as giving them milk versus flushing out the thing versus, whatever it may be. But Poison Control is always someone you should always have that number ready and available. Because even when they come to the ER, a lot of times we're calling them to find out what else needs to be done. We don't know every poison in the book. And even if we do, a lot of things have shown that if we get the information from them, there's certain points that they pull out that, we're looking at the whole picture. We're not focusing on just that poison versus they're just looking at that poison. And it works well. Sometimes if people have poison, don't just have one issue on board. They have a few issues. So we're not just looking at the poison. Call poison control and treat with that. Ask for the home remedy. That's the biggest thing. Head trauma. Send them over. Worsening insect bite with shortness of breath. like you were just saying, chest tightness, vomiting blood, send them over. They could have a bleeding varices. They could be, could they just be coughing and then vomiting a little blood in their sputum? No, don't send them on. It's not blood. That could be a GI bleed. That could be a varices. I mean, I don't know what, your population is both probably would be GI bleed before it would be varices. Severe persistent vomiting, again, fluid replacement, suicidal feelings, send them over if you can't get a hold of psych, because at that point maybe they're coming off their meds, maybe they need to get some Haldol, maybe they need to get some medication you can't get on board to get them where, we can get them to see psych right away. Even if it's not their psychiatrist, a psychiatrist can see them there in the ER. Open fractures, again, fractures that come through the skin, biggest thing, do not think you can do anything, no orthopedist can do anything for that. Send them over to the ER. And we'll have them fixed there. When not to send the patient to the ER. Minor dog, animal bites, person bite, like you were saying, not breaking of the skin. Blanchable rashes, meaning rashes that you can push down like it's red and then you push down and it turns white. They don't come to the ER for that. They come to the ER for rashes that are not blanchable, because then you have to worry about ITP, which basically, this is called petechiae at that point. Then you have to worry about, because there might be a bleeding disorder. There might be something underlying that needs to be addressed. They might be bleeding aside. What's happening here is only one spot. They can be having so many more issues within their body that you can't see. But non-blanchable rashes, that's what time you send them over.
I didn't know that.
Yeah, petechiae is you can't blanch it, right? But a regular rash, it will turn white, right? Upper respiratory infections, you don't go to the ER, right? Minor burns, you don't go to the ER. You can put some Silvadine, call your doctor, put a little Silvadine, unless it's obviously greater than, stage 1, or if it's like a 3rd degree, you send them over, because they might need more than just what you need. They might need fluid replacement, That's the biggest thing with burns. They lose a lot of fluid very quickly. I mean, they get bags and bags of fluid. It's ridiculous in the first 24 hours. That's so key to getting that patient stable. Fever without seizures. You don't send a patient over for that. Right? But febrile seizure you do, right? A broken bone, unless you cannot see ortho that same day, you're not sent to the ER for a broken bone. Broken bones don't need to go to the ER. And the reason why is because a lot of times you can stabilize it with a splint or workbooks, call the doctor, see if they could see him even tomorrow. There's nothing the ER could do besides give him a splint and tell him to go to ortho. That's what we do. We don't have orthopedists doing, in the ER unless it's a severe break and trauma requiring operation. Really. Let's see. I think I'm done. Let me just look. Anybody have questions?
I do.
Because I talk way too much.
Could you speak to G-tube, reason why you would send the G-tube to the ER?
Clog G-tube only.
Only a clogged G-tube.
Clog G-tube, not a leaking G-tube. Called GI. Why would you send it like someone with a leaking G-tube to the ER? If we can't get that gastroenterologist back in to see him, like maybe this person's tube is something that requires a little, we could change them out, if it's clogged, but if it's leaking, to send to the ER to leak versus calling the doctor to see if they can change it tomorrow is kind of like not really the way. I actually had a case the other day. A man could get transportation to the GI. His mother's bedridden. So he called up the EMS to send the mother, but said that the tube wasn't working. Comes in and says he really wants to change because it's 7 months old and he thinks it's old. Which I understand that she's bedridden, so he has no way, but then call the doctor up and schedule, call the insurance and say, listen, my mother's bedridden, I need to set up transportation. That's just one point. But my thing is, if it's clogged, we have a thing called a declogger. We declog it right there in the ER and we send them right back once I check for patency.
And if it's ripped out or falls out?
Yeah, it looks like a roto-rooter. I swear, it's the craziest thing. It works like wonders. It's great. Just twist it, yeah.
But then, Salina, if say the peg comes out and needs to be replaced.
Please, you guys don't do that here. Is that what you're saying? If it comes out,
you would do a.
We could put a yes.
Foley.
If it falls out traumatically, we will change it. And the reason why is because that's the patient's nutrition. If he doesn't eat or drink, that's it, right? But if you get to see GI that day and go to the office and get the right one put in, because we don't always have the buttons and the right peg ones. A lot of times we sometimes just put a Foley in. And the reason why is because you put the ones with all these special doohickeys in, you can actually cause more trauma to the area.
And you can utilize that Foley for the feed.
Exactly. At least it's something temporary. But that's when you send them.
And one other thing, my agency is great on saying don't send to the ER anybody in a fender bender when you know there's nothing wrong. And as a nurse, I look at the patient and say, I'm not an X-ray machine. I don't know if there's anything wrong. I don't know what kind of trauma the automobile is in. What's your feeling on that?
Well, all right, this is the deal. We had a school bus accident the other day that came in, and really the kids were fine. They were seat belted, but they came in because, again, they're in that population. It's a suable area that, if you don't do it, send them. you can send them. We'll send them to somewhere called Fast Track. It's not necessarily, they won't come to the back to see me in the main ER, but we have something called Fast Track, which is like for the bumps and bruises and little things. Send them in a case like that. And the reason why is because, you really want to cover yourself. Even if they say, nothing needs to be done, at least they can look into their eyes, check their blood pressure, check for cervical tenderness. Because a lot of times, people, when they have accidents, this is the first to be injured, usually the neck. So we just want to make sure that there's no type of compression fracture.